meeting acquaintance, Jerry. I'm going to call you Jerry more instead of
Thank you.
Gerardo. You know, I don't want to scare off our Yankee listeners. But yeah, I think Javier touched on the subject the right way. What we're not looking for is people that are so dogmatic and, you know, kind of, we say, horses with the blinders going in there, and there's nothing wrong with that. What we want are people who are analytic in their mindset, and they've been able to uh, learn things, unlearn things, and to learn new things, or augmented in their own mind and evolve through a process of thinking. And that's the process that we're really interested in, to learn and see how they evolve. So that is the interesting thing in this part, and we're looking forward to hearing your story.
Thank you. First, I want to apologize to the others um, interviews because I don't have enough time to see every interviews. Uh, I would like to remember that hotel bar in Madrid to 2015.
People
Uh,
say that. Can you talk louder or
okay,
closer to? Perfect.
it's okay.
Yeah,
Yes.
Better.
better.
Okay.
Thank you.
Uh, the, I just tell that I would like to remember that hotel bar in Madrid. Um, the first time I saw Javier was on a slide in the Rocavados TMJ postgraduate program. And in this hotel, he was with a Cuban cigar bar, whiskey. We were Facebook friends, recognized each other. We started talking for 3 days and 3 nights until today. We don't stop talking
Yes.
about occlusion. For both of us, is our passion, is this advice. Thank you for being my good friend. We are also united that your daughter and I were born the same day in June, not the same year, but the
Oh,
same.
really? Wow.
Yeah. And
I love
thank
you
you
more
for
now.
letting me. Yeah, thank you for letting me share my vision and for honoring me with being among these great professionals. And thank you, Hamid, for moderating the interview. Uh,
Pleasure.
I want to start with a sentence very important for me. I always said it to all my students. All things are inexplicable until they are explained. This is from a TV freak series, Fringe. I don't remember the year, but
Good.
Hamid, please write it. All things are inexplicable until they are explained. This is why I want to see all the interviews in order to be able to say things that have not said. Because when you see, for instance, for example, the spaghetti test, the second time you are able to say all the lie has been known that the spaghetti test is recommended to improve the lip sealing. I'll try to do my best. I want to tell you my process with three anecdotes, three histories that are the key to understanding my process until this interview. The first one happens
Okay, we
in
need to speed up. So let's go by segment first. How would you get from a pure natology perspective?
I'm coming. This is first happens in Bogota in the year of 1994 when I did my first implant prosthesis supported 3, 4, 5, 6 in three IM set implants, impacted implants. That was before starting the prosthodontic degree. I put it, and it's important to know that I studied at the Javerianas University, and we were their close natologists, Stuart, Peter Neff, Peter Katomas. We do natologists, pure. And my patient had a unilateral crossbite, and I left her occlusion well with a canine guide. I left, and when I returned from vacation, I see the patient again, and she tells me that her prosthesis has broken, that if I can fix it. Okay, no problem. When I unscrew it and I remove it, she puts her hand on her knee and says, "Oh, it has stopped hurting me. I have had 2 knee surgeries for pain and the doctors do not know where it comes from." She opened her eyes and says to me, "It hurts me since you put me this teeth in me."
Wow.
I put the prosthesis back in her mouth and screwed it in passive adaptation. And the pain in her knee came back immediately. It was impossible to believe until I put it, but I didn't fit properly. She bites and tell me, "Here, this does not hurt." I look, and when I was cross it again, I wear the contact until I leave the prosthesis again in a crossbite, and where she tells me, "Does not feel anything in the knee. Okay, it's perfect." And she says to me 2 sentences that marked me forever. Thank goodness it happening to me. She's a very close, familiar person, and that happened at the beginning of your practice. So find out why. Now, when you have to understand that I come from a poor country, Colombia is a poor country. That means that if someone has an oral rehabilitation, what is the best option to work? The natological one or the freestyle occlusion? Because I want to optimize my work, and they do not break. Otherwise, the patient will not come to my office, and I will have to pay 2 or more times to the laboratory technician to repair them. Then don't is in Catalan. So I remember a teacher, Professor Richuli. Richuli was a teacher of complete denture. He told me the healthiest gum in the mouth was when there were no teeth. It's obviously it's a edentulous patient. Okay, and another great professor, Juan Manuel Gonzalez, who in one class said the most stable tooth periodontally is the one that it works well. So I'm starting to obsess it with the full denture. If plastic teeth work well and do not have support, they must be made to work that way, but with dental alveolar support. This is what I mean. Well, I've tried to modify the dental anatomy in a specific way, the trajectories. Well, we will spend hours just counting that process. My technician went crazy. Bueno, Orlando, poor man. Well, all my technicians, Uriol, Raquel, Jesus, Pep, having to endure me, it's impossible. I take almost 12 years to know how a crossbite can cause a strain on the knee. The second one happens here in Barcelona. In 1999, when I was studying the doctorate in pH of saliva, and Angeles Jimeno sent me to my great mentor, Patrick Bach. He's from France. And this dentist, to make a filling or whatever, an endo, and check the occluded well, for instance, use the patient leg or the arm and evaluated if the muscle tone change or not. But this in all the treatments in the office and in all the patients, that exploded my mind. It took 10, 12 years to know why this change in tone was happening. I think Patrick, he gave me the vision of entire body, applied kinesiology, posturology, osteopathy.
Gerardo, we're never gonna finish. We need to go faster.
Okay, well,
go to the point.
Okay, I begin to see the whole body can change the mouth, and the mouth can change the whole body. If you study posturology, there is a very, very learn in Italy, all human problems, everything, even the COVID, are caused by the teeth. I am a dentist, it's perfect. But if you go to France, half of France solves everything with the osteopathy, and the other half with the feet, with the insoles. Everyone solved with the eyes. And in England, everyone solves with the vertebra. And in Portugal, with the eyes, in England, with the vertebra, and Germany is with the recovery of neural information, and in Spain, everything is emotion. Everything caused by the emotion. If you have a caries, it's emotional. If you have everything. So well, that means you have to learn everything. No. In posturology, is obviously you must be able to understand if you can stabilize the entire neuromuscular system, for example, with osteopathy, insoles, visual therapy, spleen therapy, whatever. The stability should offer you an improvement of nociceptive symptoms. When I speak nociception, I mean two components of nociception: pain and tissue damage. Pain or tissue damage. Pain / tissue damage. This is a key point when you put together occlusion and posturology. If you can
Gerardo, let me stop you
stabilize.
there for a second. Hold on, because honestly, we already have people that talk about posturology, but still, we don't know exactly what you guys measure. And I know that you're really special with the eyes. And so let's. So
okay,
remember, Gerardo, I love you, but remember, we need to make it condensed. I want like the principles of posturology, eyes, magnet, insoles.
It's the movement. It's the movement.
Okay. So tell us a little bit about the principles of posturology and what you measure, because it's people that in posturology, they do a few things and other ones not. Like we personally, we don't do insoles, we don't do magnets. We use the tools.
Yeah, but it's a lot of it's like a tree. Posturology is like a tree, and it's a language. We can talk all together. The optometrics, the podiatrician, the physiotherapists, whatever, they can use this posturology like a language. You do a test because the entire system works. If the visual perception affect the position of the head, the vestibular system affects the position of the head, the muscular system obviously affects the position of the head, and the relationship between the foot and with the ground. And all together analyzing are analyzing by the posturology. We analyzing this oscillation of these muscles, these tone muscles. But let me finish about the dentist and posturology, because I thought, think about that. I thought when I talk about the complete dentures work and there are no teeth. When are there no teeth? When we are newborn, we do not have, and we run without them until they erupt. But when you already have them and they work, you have to change them. Why? Nature is not like me. I need to do things 1,000 times. That I discovered a great pillar of my knowledge is the evolution. A message that I always try to transmit to my students and to everyone is, please do not invent. Please try not to invent. Copy, just copy, man. Copy the evolution, which has repeated millions of years, and look, you have come out. You can learn a lot about the evolution of the human being. And that is when I studied the mouth worldwide, the teeth erupt. I discovered in orthopedics and functionalists, IFUNA, International Functional Association. I don't know, maybe John Mew, orthotropics, theory, Pedro Planas, Armenio, Aragao in Brazil, Sandra Coulson in Denver, Josephine Desayes treating before the age of 6, Vilma Simões in Brazil, Facal, Recatero, the spine, scoliosis with the mouth, a guy who called Emilio Lopez, who cures with a olive seed, Susan Ibar in Peruvian speech therapy, Roberta Guedina, Marisol Dorronsoro, and the body awareness. The list is endless. But all those wonderful people who are all over the world studying how the stomatognathic system works, they can all teach you a trick or a technique or something that you had not considered or something that you stuck you and does not let you advance. Multiple devices, multiple techniques. Tell me.
Excuse me. So what I'm hearing is that you've studied a lot of people who, excuse me, have been able to somehow connect all these different other systems with the mouth. So
okay.
And it comes back to the same thing that most of our speakers have talked about, how to them the occlusion or the bite is more than just the teeth digitating. So tell us about what do you at this point where you put all this knowledge together, how do you go about, and what factors are you really measuring, and what are you seeing when the patient walks in? What are the cues you're looking at?
Because we want that position, and we achieved that position. We improved that position, and all the factors are in common. The eye, everything in the whole body is has something to talk. When we improve the position, the movement improve. And if you want to say the position of the temporomandibular joint improves the movements of the temporomandibular joint. But this is important to understand because it's out of the disease damage, the tissue damage, or out of the pain. If you can take out the pain, the receptive response, you can do whatever you want. And this is how the functionalism works. How can you do that with the evolution? You just try to understand, well, the orthopedics create a way to show you. If you have 6 months, you just do a few things with your mouth. Sucking, breathing, swallowing. But if you do, if you're asking the patient until 4 years, you do a lot of things. Chewing, but you cannot whistling, for instance, until you have 7 years. This development, it's important to understand how can we introduce functionalism, how can introduce orthopedics, and how can find the position to create a very good movement since this position. But let me tell you one thing. How can I introduce a Slavic concept in here?
Yes,
because
yes.
Professor Sadao Sato he comes to Barcelona, to the University of Barcelona, and I asked him if he controls the occlusal plane in the sagittal plane, and Professor Slavic controls the occlusal in the frontal. I understand the planes of the space, the occlusal plane is controlled. But who diagonally controls that plane? And this Japanese guy, man, look at me suspiciously. No, it's a joke. And says, go to Vienna and asking him. I come and ask him the first day when we introduce ourselves, and he says, sit out and you will understand. In those days, I had the same feeling of frustration, sadness, abandonment that I had years ago with Professor Rocabado when I heard his 50-50 concept. The same feeling of frustrated, helplessness. Uh, I received a class from Professor Slavicic for 2 hours, just talking only about the first molar. 2 hours. How could be happening to me again this? It's impossible. My head is exploding. 20 years of practice and I don't know how the first molar works. It's impossible. In 2015, I was finishing my doctoral thesis in neurology on the relationship between the vestibular system and the kidney. I gave the professor a free of the thesis to read it. When I asked him how he thought, I take advantage in asking him about the occlusal plane. And he says, "You explaining to me the first day. You know who control it." What? But did you make me do all the courses? How many money spent here? And he said, because you did know what was going on in the mouth. And with the process was like step by step to solve it, to keep it. Every step and every action require a carefully analysis that you must learn before involving systems as complex like the eye or the vestibular or the feet. Now that you know how it's done, now you have the tools to prove it.
Okay, so let me break up for a second to wrap it around. So you were doing posturology first. That's why like your eye openers, so you get to able to see what was the influence on posture. And then you continue doing what you were doing, regular natology simultaneously.
Sometimes,
and then your brain start thinking that was something else, right? So that was at least the posturology make you understand that the human body was a little more complex than we expect. And that's when you start digging, right?
Yeah.
And you went so then you went to Tech, and now you learn some principles, and now you're going to integrate both.
Exactly.
So now to the people, in the other lectures, we're talking about that connection point. So what is the principles about what the philosophy of Slavicek, what is the principle, what they take as a consideration? Again, we have the disadvantage that here in America, we don't know anything. So we deserve
but
to have
you have Latinos in America and here. I'll be quickly, I promise. But you have to know, to understand philosophy Slavicic. You have to understand this field. We were sent to do a group work of Portuguese, Spanish, Latin group. We had to take some photos with specific parameters. They gave you the material, and the flash did not work. So we took the photos, playing with the speed, and we presented them in the Gamma software. Elot Ulri, our teacher, Hungarian, Slavicek, square, Slavic guy. Great photos, but the photos are not made with the established diaphragm and speed protocol. They do not work because they are not reproducible. You have to repeat them. Everyone's face was the same. Some of us went to repeat, and then the great Nelson Opperman bought a Photoshop program that changes the photos at the speed and appeared to be one. Everything was redone in 20 minutes. And we called it Elliot again. When he saw us, he started to look and made a face of disbelief and asked, have you repeat them all? And all the Latinos shook their heads, affirming that, yes, we did it without talking, without looking at us. All Latinos who are watching this know what I'm talking about. if you want to follow an exact protocol without failures, everything measured and perfect, Formula One style, please go to Vienna and learn. Because Professor Slavic's philosophy is based in how the entire masticatory organ has a relationship in what he calls a cybernetic system. There are different parts of that compose it, and this interrelation is very well structured. The aims are the stability of the masticatory organ. He get it and maintain it in long term, because he analyzed all possible details and measured them all, evaluate the craniomandibular system in dynamics, because the static relationship for him are secondary. The occlusion must be adapted to each individual situation. That is not yet allowed. If it works normally, and the concept of sequential occlusion with canine dominance, it's applicable to all skeletal types and adaptable to compensate malocclusion forward. We use the condylography. It's based on the 0 point of the healthy joints, which is a concept in physiotherapy, and it's possible to reproduce a hinge joint rotation axis, which is a line between the two condyles, and it's very close to the lateral point to reduce geometric distortion, which serves to have a reference position or a therapeutic position. They are evaluated in addition to traditional oral movements: open, close, protrusion, protrusion, medial protrusion, lateral protrusion, free movements and function, such as soloing, chewing, speaking, but everything with a strict protocols. When we do a condylography, for example, the chewing part, the apple given to the patient should be the green apple with the skin, cut especially. He has to do always the same, but I do the Latin way, my man. I do showing condylography with a Spanish ancestral tradition. That is to eat
in
some
the
flower
audience is
seeds.
asking about, I don't even understand clearly, is something about a sequence of this occlusion? That
Yeah, canine guide and desocclusion sequence is every teeth has a desocclusion angle compared with the occlusal plane, and this can measure it at the position of this exactly each angle. And there is a very complicated program. You have the measures of everything. You can measure palatine, side of the central, lateral, canine in all the points. There, it's a very complicated. You have to go to Vienna to learn for 3-4 years and understand. But if you want to know exactly how is the inclination of the first premolar left, and the difference between the first premolar right in the palatal cusp, you know that because you have it, and you can reproduce them a lot of times, and you can create it into the articulator, because we have different, it's a complex system in the articulator, but this is the Formula One. You can do that. But you are talking about Iceland, the desert island. And
okay, so now let me stop you again. I have people in the audience engaged, so I think it's people that know the philosophy, and then I think they want that you mention these things. And again, I'm neutral. I'm doing this for learning purposes. This is not political. We're not trying to prove who is better. I respect the people that is in the audience, and maybe since you guys represent this, that's why you want me to guide Gerardo to some questions that maybe for you guys are important. We're gonna try to do the best, but you guys need to understand this is one of the concepts that I have no clue. If you see the other
Exactly.
material that I was able to interact and make clever questions, is because that's what I use integrated in biofunctional dynamic occlusion. But this concept is really far away on my spectrum of knowledge. So I apologize for that. So people is saying here that a few things. So they talking about the sequence of this occlusion. They talking about the disocclusion angle, and they talk about that disocclusion angle is directed to the SCI, sagittal condition inclination. It's something that
Inclination.
should be important. Can you relate something like that?
Yes, this is a reference. You have a reference position because it's important to understand that in healthy joints, a healthy craniomandibular system, it is possible to reproduce a hinge joint rotation axis. And sometimes perhaps it's maybe your therapeutic position. In my experience, my reference position, which is 150% of the time, is that of a diseased joint, and it doesn't match with a pure rotation. There is a medial occlusion or lateral occlusion for sure, but you can reproduce this in healthy joints. And when you have this hinge joint rotation axis, you have the reference of sagittal condylar plane, and it's like a structure thing, and you can measure everything with this basic rotation, and the condylography give you the opportunity to create exactly the shape of the teeth with the shape of the movements of the temporomandibular joint, how the rotation is controlled. Because, well, in the not healthy TMJs,
Yeah, that's what people want to hear, because people say we don't have normally patients.
Exactly.
So how is dynamic?
Well, in no healthy TMJs, always make a different movement from rotation. First, because the temporal bone, but this is my opinion. First, because the temporal bars are not asymmetric in position. And second, because the muscle tone, not muscle contraction, is involved in factors in the joint. I think the viscosity of the synovial fluid, the viscoelasticity of the disc, arterial supply, and this tone is conditioned by the eye movement and the position of the vestibular system into the petrosus process of the temporal bone. The eyes move the suboccipital, and the vestibular moves the head, because the suboccipital move the head. So you have to take into the equation the eyes and the vestibular. It's impossible to understand temporal bone without these two elements. And this is how I talking about, because I'm talking about the condylography in the Latin way. I do the condylography eating pipas, a kilo of pipas. And this is typical from Spain.
Pipas.
This is typical from Spain.
We
created pipas
sunflower seeds.
Sunflower seeds. The Spanish are very professional people eating that, and it's so fantastic when you measure this rotation in healthy people, in child. They do the same movement 1 time, 2 times, 3 times, 4 times, because it's a cerebral. It's from the cerebellum. It's not learning, because they know how to do it. And this is very important to understand after that, how the functionalism, how the brain understand the occlusion. Because it's
okay, Gerardo, how many phases during the treatment in this philosophy you guys take as a consideration? So you made your initial analysis based in posturology. What is it? Give us a little sequence about what you do. So then again, I'm no clue about this philosophy. So I don't know, you guys make equilibration, make appliances. What you guys do? You pay attention only to the joint, you pay attention to the
No, 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 no,
airway.
no, 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 no. We can pay attention of everything. Everything has something to do. Uh, every
No, but into
function
the
of the
process. I
muscle.
know that you have a
Yeah, but
huge influence by the posturology,
no,
but
no,
let's
no.
talk about the pure concepts.
Yeah, but in the Slavic concept, the craniomandibular system is a cybernetic system. Everything is involved into the philosophy. So, and you can measure it, everything. And it's so important, the muscle palpation, to know if the craniomandibular system is in the healthy process. If you don't have this muscle palpation in the correct process, probably something is wrong. And you have to put these these not healthy people into the healthy people.
So what you treat first? You treat the muscle, you treat the joint, you make an integration.
I or Slavic.
I mean, give us the principle and then why you modified it. I mean, it's simple like that. Like my foundation is neuromuscular dentistry, but I have different things that I adopt.
Okay, I know I am in the right track because Professor Wilfried Janik, a German bioneurologist, an expert in enteric system, gave me an outline, a schema of the interrelationship between the three ways of perception: the oculomotor pathway, the vestibular system pathway, and the trigeminal pathways, and where and when they are interconnected in the brain. And my conclusion after this one is the billion-dollar question is who really moves the temporal bones? Mariano Roccavado said the important is the fossa, and Professor Slavic is exactly about all the craniomandibular system has a correlation between the movements of the mouth, the jaw, the movements of the craniofacial system, and the teeth. It's a very complicated thing, but he do it. And the answer is simple, and at the same time is so complex, because all the interaction is difficult to understand, but you have to take care of each part of the system, and this is the problem. It's not it's not like a recipe.
Okay, I'm sorry that I'm cutting you because we still, I need to have an idea about the entire process and I'm not. How you guys, so it's multiple ways to make diagnostics. So if I understand correctly, you guys support yourself with a software that help you to do the diagnostic.
Exactly, we have the diagnosis, and we have a sheet, and we do a muscle palpation specific. We have parameters of palpation, anamnesis, and they gave you the opportunity to know what is exactly, when is the pain, where is the pain, how is the pain, which part is involved into the pain. Okay, and we do a muscle palpation with a structure form. And this is one part. We take photos, photograph in Slavic philosophy. Take photos of the face, whatever, mouth, models, and we do a mounting in ICP and RCP position, res condylar position and intercuspidal position. We create this position. This is for the diagnosis. We do the condylography, and the condylography we do with CBCT points, and all is into the program, and everything happens into the program. We see that's a lot of sheets, and you have all the measures, how can you put the correct part of the models, the inclination of the teeth, anterior inclination, posterior, where is this condyle, this other condyle, how it moves, and you can reproduce. Everything happens into the condylography in articulator, a total complete articulator. You can change the angle of the condyle in each part of the planes of the space. If you need to, the position of the right is 2 millimeters, 1 millimeter, you can do it, and you can repeat everything. There's a structured waxing method for class 1, for class 2, for class 3. And there's a therapy with the splints, there's a therapy without the splints. If you don't have the correct position of the teeth, you go to the orthodontia with Professor Sato and his method about mu concept and position of the teeth. And this is another interview. And the final goal is the aim of stability of the craniomandibular system. I think it's a lot of concepts in the same place. We try
Gerardo,
to,
how you guys? I apologize again. My wife did say that I'm so rude cutting you off, and maybe I'm abusing that we're friends, but I just concerned about the time, and still I need to have like a sketch of the same question so people can create an opinions. I have people in Facebook giving opinions, but I'm gonna try to be into the positive side. I never bring you as representing you. I want that you, since no information about the philosophy, you kind of tell us. I don't want to disrespect any of the people that is in the audience, that they in the same philosophy, but they have.
I respect the philosophy. I respect the philosophy of Professor Slavicic, but I use it only to measure my fins, my Latino fins.
And this is what it's about. Again, that's what I explained the audience here. This is a personal interview. This is people, I'm not trying to show who's best. It's people that wants to be interesting, like Gerardo, with his knowledge and in the way that he orchestrates his treatment plan. He's taking pieces for different parts. That's totally okay. Again, the entire idea here is that we learn something. We get inspired. I get my understanding is you inspired by the School of Vienna in the way that you talk and everything.
Yes, and this is probably I'm not a dogmatic Slavic student, because I believe in the temporal bones, and I believe it's the wonder of the nature. They contain the entire auditory system, the vestibular system, but it's only fixed in the portion is fixed. The rest of the bone has to form, grow, adapt. The scamus part has to rotate until it fixes. The mastoid process has to stretch to form the styloid process. In the same is with the mastoid process. All the fossa subtemporal have to change all the life. That means in the free planes of the space, you have to process functionally with everything. And the Slavicic concept allow me to measure that crazy thing. How can I measure? Because I have a very complicated program and I can do whatever I want. A French kiss with the condylography, perfect. Another thing that is passing in your mind, but it's not a schedule to talk about it. So you can create whatever you want, whatever you want, because it's a great tool to understand how the temporomandibular joint works.
Gerardo, how you guys take the bike registrations? That is important. We're getting close to time.
I follow the method of Elot Ulrich. Is published in the Journal of Prosthodontics. He do it with a wax, a pink wax and alu wax. I don't know if in the United States it's the same, alu wax and beauty pink and alu wax without touching. without touching. All the patients, this is another difference between how the posturology are involved into the occlusion, because they do a little pressure, 5 grams into the point of the chin to help to rotate forward, backward, and take this bite registration. I do it without, because the tone of the muscles of the eye, I don't touch the patient. If I put my finger in, the muscles tone are the same. If you have problems with this, it's probably your head is moving. And I use all the tests in posturology without touching the patient, because if you manipulated the patient, you have a problem, because it's your
distorted.
Yeah.
Okay.
So is this concept, the way that you take the bite, is how the school of Vienna take the bites, or not? Or this is your personal way?
Yeah. They do. But okay. I'm not touching the patient. I just teach the patient.
So are you guys taking as a consideration the muscles?
Yeah, everything, every muscles. The
and
muscles
how
are the.
You get the how you get balance into the muscles? What is the technique? I'm just curious.
To take this, because you know what happened exactly, what in that muscles when you do that movement. If you move that, these muscles move. If you are here, if you know the position, you know what muscle is not working well, or if this is working well. You know exactly, because it's a relationship. The vectors of the muscles are very clearly. If you have we use occlusogram. It's like a walks, and we see the interference in ICP, in lateral occlusion, medial occlusion, protrusion, and we know exactly which part of the teeth are creating the interference. For instance, if you know the interference in one side, you know how is the muscle isn't work in the other. They are all structured. I don't know if I am clear with that.
Yeah, I was. So you taking the most of the consideration, and it just still. I apologize. I'm kind of stupid today. I wake up too early. Maybe my brain is not working correctly. So just to wrap it around, you make an analysis. Big part of the information is coming from the posturology part. Then when you check everything, then you use some softwares and articulators to kind of try to reproduce the movement of the patient. The part that we don't have clear is like a we neuromuscular doctors or philosophies like biofunctional that has influence on neuromuscular. We use transelectrical stimulation to relax the muscles. It's another people that they try to use Lucia G.
How can you relax the muscles if you don't take in the situation into the equation the eye? It's so easy to know. If you see my presentation tomorrow, I will show you. I change my presentation now. I show you how, if you don't see with the two eyes at the same time, you don't see in 3 dimensions. That means you have to put your head. It's easy. The middle line is for the eyes, and the middle line is in this place, and you are from evolution. You have your vestibular system perpendicular to this, and if your middle line is in this position, your horizontal plane is here. The horizontal plane is not there. It's impossible. It's inside the temporal bone. So if you are there, this is your reality, and this is correct. This is healthy. This TMJ is lower, and this TMJ is upper, because your perception of reality is the eyes, and you can establish whatever you want. This is not talking about the contraction of the muscles. It's about the tone of the muscles. And if you touch the tone of the muscle, you change it. But we measure with the myotone. But this is in posturology. Think about the first one. The first thing we have to do is the anamnesis, almost an hour. I consider that it's not wasting time, but it's invested. The postural physical exam is a visual capture, cover test without in an Iceland with the hand, proximal point of convergence, max, Maddox. The vestibular capture, a Romberg, clinical test of sensory interaction, Fukuda, the stepping test, bucket test, subjective visual vertical, the foot, unipodal support, stabilizing chains, neutral standing position, walk, goniometrics, extension, flexion, flexor rotation.
Gerardo, you guys make orthosis appliances? You do with superior, okay? It's open or part?
In posturology, but in my office, I don't know in posturology. In my office, we make photos with glasses, without glasses, with the spleen, without the spleen, with insoles, without the insoles. And we measure everything. We create a videos and photo videos recorded of everything in every positions in the space, and we compare this. That give us initial diagnosis, and we determine the priorities. The system is hierarchical, and two basic parameters: how its function embryological, and how the neurobiology development is. When you know that, you can go to the whatever. The osteopathy, he put the head in the position, you do it again, it's just 50 minutes. Diplopia functional, diplopia, far diplopia, near diplopia, far diplopia.
Far-sighted.
Yeah, near diplopia.
Gerardo, I love you, brother.
You know
please
everything.
stay into the subject.
Okay. Stop.
Question is, yeah, no, I'm sorry because I'm sounding rude because I have to stop you, but it's not my intention. I'm trying to moderate the interview in some way. And you're getting out the subject, and I still don't know if in the Slavic check technique you guys do appliances or not. If you guys do,
yes.
Wait, let me finish. So you go because time is a problem now. We really
we're already at the 1 hour mark.
Yes. And then still I don't have clear things, and it made me worry for the audience. We want to know, you guys do appliances, if you guys do appliances, if it's upper or lower, and if this appliances has any specific design, it has anatomy, if they're flat.
Specific anatomy, there are a lot of spleens, 3 or 4 partial spleens, lower spleens, upper spleens, fixed spleens, 24/7 days of spleen, 2 weeks of spleen, emergency spleens. We have a lot of
how long it takes
possibilities.
to the formation at the School of Vienna, just to have an idea?
How many what?
Like how long it takes to learn the concept? I mean, just because it looks really deep and fascinating. Yeah, how long it will take?
To well all your life. 2 years, 3 years. Not total complete. You have to go practice in your office and come back, and the basic course is 6
modules,
6 seminars, and you involved inside, and you never stop to learn, because you start to know people who work with that 40 years, and they show you the patient, and you say, I want to do that same. Think about it. He is very successfully, but you have to do this concept in all the correct steps. I am a Latin guy. I am not do all the steps, and I do my steps. This is the problem, because between his philosophy and my opinion of the thing.
And that is valid. I think we all learn in one way, and we translate it in the way that we think, or even we can teach the people.
All right. So let's take a look. So you take all these information. Then you formulate your diagnosis, whether it's, are you guys looking at similar parameters at the end of the day? I mean, it looks like you're looking at a lot of neurological parameters, but are you looking at joint pathology, displacement?
Obviously.
And all that, and then reposition it. So when you take your bite, are you guys looking to recapture the meniscus and
yeah, but you are thinking into a little box. We are in a big box. This is a big box.
I'm trying to understand. Correct.
Yeah, think about this guy. Think is movement is important, not the static. The static, yes, it's something to take care, but the best important thing is movement. And who moves the temporomandibular joint? Who moves the cranial system? Everything is the muscles is the worker. The brain is the boss, and you have to go to the boss. If the boss create a very good order, the workers will do. And how the boss do the orders: breathing, sucking, swallowing, chewing, and I added oculomotricity, eye vestibular coordination, eye-foot correlation, and how can we start to do that? We achievement of the resting position, stabilization of the movement from this resting position to the therapeutic position, or probably the same. If coincides the reference and with the therapeutic, well, we can do prosthodontics or orthodontics, and after that, prosthodontics is multiple.
This is fascinating how open is the spectrum. That is beautiful.
So
I'm sorry, Gerardo, to put you in the spot before. I know that is tough because you develop the way that you work. And again, all respect for all the philosophies and all respect for the people that is watching us.
Yeah, probably I'm a how do you say hereje in English? I don't know. Hereje.
Oh my God, I don't know.
I don't know. Well, probably I'm not a good speaker from Slavic philosophy. I'm talking with Christian, and I talk to him. Probably I'm not the very best guy to talk about philosophy.
Because we didn't want to get into that connotation. We want to see your perception, that I think is important, because I think the structures of many philosophies
it's my perception.
Relate. This is good. Now, but the only clarification that I want to do is that maybe in the future, I want that you guys understand that we plan this based in what we know, and this explanation goes to the audience. We plan this in based in what we know. Gerardo, I didn't know that he was doing this. And again, since I have no authority whatsoever to know, I'm like following what people is commenting. Maybe people is thinking that they would like to hear that you say more or different, that is all valid. But then I will apologize with the people. I say, okay, this is the beginning of a project. At least we're interested to talk about occlusion. And that's the beauty of this. Correct. Again, here, if the world start thinking more about the positive things and less about the negative, I think this is the message that we get for this COVID, this coronavirus.
Yeah, I'm so sorry if someone near to the Vienna school feel this is not the philosophy of professor. Okay, I use the interdisciplinary approach. but I use posturology. My office is a posturology. It's not a dentist. I am a posturology, but in which all patients I'll list 4 professional optometrics, physiotherapists or osteopath, podiatrists, and dentists, 4 visions of the same patient. And the different professionals also refer us the patient so that we can do the dental part of the postural control. And I use the Slavisec Latinos way for my function, and I can measure it. The professor not measure the eye. I'm sorry, but I'm talking to him a lot about this. And I measure the eye. Now we have the possibility to measure everything. Everything means the stabilometry. It's like we can measure the movement of the body. We can measure. This is in the feed, but in the visual converge for the eyes, we can use a programmatic, program.
I'm sorry.
In the mouth with the T-scan, we not use the T-scan like biting. It is stupid. It's a movement. You have to bite and start to waiting for the oscillation. For the TMJ using the condylography and the gamma system, and for the tone using myotone. So we use a lot of things to measure the parameters of each plane of the space individually and collectively. This Gerardo, is what I want to
let's move to the next phase at this point. Let's answer some questions
okay.
So that we can get some sort of form to bring things together. So is it fair? Our first question is, what is occlusion to you? From what I listened, is it fair to say occlusion to you is the health of the central nervous system? Because that's what it sounds to me, that you're looking at really the neural pattern of how all of this is controlled. So it's not just the teeth and bite to you, you're looking at the whole bodies and how the central nervous system is controlling all these different systems. Is that correct?
I think the occlusion is a process. It's a cortical sensorial process, and it's carried out by the stomatognatic system in the hardest tissue, the enamel, the dentin, and the root segment. And this contact provide the initial and the final position of the body movement, because the body is always movement. The mechanical balance in human, in physics, doesn't exist because your heart is beating. Your blood must come out and return. Your temperature is here, and you have to create this stability. This is the tendency of the bodies to find the equilibrium point, and that can be measured because it's oscillation. When something goes from one side to the other side and passes twice through the same place, this is the definition of frequency, and the occlusion is a frequency. If you have a T-scan, you just take only bite, and you see how it's moved, and it's a parameter. If you close your eyes, it's different, the movement. If you cross your legs, it's different, the movement. If you take a break and wait, it's different, the movement, because your body is always moving. But if you move, you can measure how, with the frequency of this stability. This is my think about occlusion. Occlusion is when the hardest tissue, the dentin enamel, the dentin, and the root segment talking together, starting and the initial and the final position of the body. This is my opinion.
All right. So can you quickly go just through the factors you're looking at? You mentioned posture, and
I look everything from head to toe.
So
in the mouth, we analyze 43 oral functions to ability to beatbox. If you can do this, you have a problem. I am a very old guy and I not know how to whistle. This is a problem for my muscular system. So I look everything from head to toe, and we do not stop falling.
Let's talk about some of the stuff that that we're, for instance, looking at. Like, how about airway? Are you looking at and analyzing airway?
With Franklin Susanibar test, his speech therapist, we measure the hold, the function of the nasal muscles, the air breathing, measure the air breathing, the line. We use a lot of parameters to know how the oral breathing is function. And we improve the lip sealing, and these parameters has to be better in time, 3-4 months. Sandra Colson, how can you close your lips? We use a speech therapy, another from functionalism.
Functional therapy, you guys believe in my functional therapy, getting the oral function back?
Yeah, we use to close the lips is the first thing, and you start to know where you have to put the tongue, how you can resolve the rest saliva.
Those are common grounds as we were looking for. Those are you know, the first part of what you were explaining, it sounded so really, honestly, very complicated for somebody like myself, completely ignorant of all these systems. It almost was like all over the place. But talking about some of these things are stuff that we understand that, yes, we're looking for these muscular function. We're looking at it as a system that, unless all the parts, which is the muscles, the joints, and the teeth, they have to be working.
Don't complicate the system. Don't do that.
Okay.
Copy the evolution. What do you have to improve before the teeth?
Well, you know, we also think about it, but we don't quite think of it that deep into the central nervous system. We just try to control what we can control, and try to get the posture as best as we can. And
I mean, the eyes is fascinating. It's just deep to understand, but it's fascinating, the eye control. But that is
if you don't know how to breathe when you have your six erupted. Before that, you breathe until that day, until the day your six erupted for the first time, until your first erupted and your fist touch it with the other, you have to breathe. And how you breathe? The importance is you can do functional things before you have teeth, because the teeth are the structures. Hamid, it's so easy to understand. Your middle line is here, the two eyes. You have the middle line, but you are a baby. You just cannot put your head in this position because your sternocleidomastoideo is not aligned. It's not strong. It's strong. When you are strong, you see in 3 dimensions. You see your hand in 3 dimensions because you have reflexes, archaic reflexes. It don't let you see correctly your hand in 3 dimensions. When you just got that, you start to put it in this position. The vestibular takes this position and is perpendicular to the middle line. And when you stop your head, you remember you have a kiss. When the kid do it this movement until they find the structure. Think about why the nature put all together 64 the better endings of sensory, galvanoreceptors, baroreceptors, everything is in the mouth, everything. And how can you protect it with the free hardness tissues of the body? Why? To eat is stupid. It's to maintain the head in the place when you breathe and when you swallow, because you need a structure, a wall. This is why the 6 stop here. The centrals erupted at 6
Correct.
months, because you know where is the
So the way we look at it is that it's given a stability to our head over the C1 and C2. So that's how we look at it. It just seems like a little bit more, maybe deeper look of going around explaining it. Gerardo, can you tell me briefly the diagnostic tools that you use? I know you go through a detailed both postural exam and oral exam, but some of the tools that you use, tell us about it, the machinery.
The machine.
Stabilometry.
Stabilometry for the feet and for entire body, but the pressure stabilometry platform, the visual convergence of the eyes with a it's a informatic program in optometrics. You can see the field for the vestibular motion sensors in darkness, visual vertical subject. For the mouth, the T-scan. For the TMJs, the condylography from gamma. From deglutition, I use with
is Gamma the company that manufactured the equipment? How's the equipment called? Gamma.
Gamma software. And for the tone of the muscles, myotone.
Myotone. Okay, so you do
myotone. This is and we put all together. We create a pattern of treatment. First of all, before everything, we have to improve nociceptive way. No pain, no tissue damage. If you have
we're gonna get
TMJ,
to that. We're gonna get to that. Gerardo, do you use an interdisciplinary approach? Meaning, do you use other physicians like chiropractors or DOs?
Yeah, no. We are a posturology consultation. We have 4 dentists, all in posturology. Orthodontics knows posturology. The osteopaths know posturology. Different kind of osteopaths know posturology. The podiatrists know posturology, and the optometrics. Everyone knows, and I do the dental part of posturology in other professionals. Someone near to my office send me the patient. I do the part of dental part of the posturology, and
yeah, that was my question. What other professionals? So you work with an osteopath. How about a physical therapist?
Yeah, every day. It's impossible. Okay. It's impossible not to work with them.
Correct. Fantastic. All right. So the sequence of treatment. Who sees the patient first? Do you see normally the patient?
I do.
Okay, and then you kind of
organize
who sees. Okay, so tell me. Let's say you see a patient and you said, okay, we got to first. How do you go about? First, do you start correcting their posture?
Do you fix why?
Where do you start first? Do you start with an oral appliance or do you start with other professionals?
Normally is with other, but if you have a strong pain, we use splint therapy.
Like a temporary,
combined with the osteopath.
Right.
Normally it's, but if you have vertigo, for instance, this is a very good point. You have to change the vertigo first with the vestibular therapies and introduce into the postural control, because this is like a parasite. Nothing into the body understand nothing until this parasite goes.
So
goes.
What is that?
first
That first
twice.
appliance that you put, how it looks like? That one that you say that you will use in that case.
No, I create first of all distracting
The joint.
yeah, with exercises, distracting, elongation, distraction of the TMJ, and when we have this position, this is after 21 days, we start to using the bike with forces who create like a tension in the muscles until the muscles are no response, and we copy that position.
So can we say it's
And they
correct to
go to
say
the
it is correct to say that the technique that you guys use is to fatigue the muscles? Is that appropriate to say?
until find the reset point. Exactly, it's a therapeutic process in physiotherapy. You move a muscles until you have the 0 point, and when you have no response, correct response of the muscles, you can copy that position, and it's a very natural position for the patient. The middle line coincides. It's
How
very reproducible and very comfortable for the patient at the same time.
Yeah, I think the other day you explained me something like this that you use to enhance your hand, you know, these sprints, something like that. So now my question is, when you guys put these devices that looks like it's something that has sprints that make it resistant to be able to fatigue the muscle, is any specific position that you put it? It goes into the inside, so uh, I mean, I have no clue how they looks like. So it's something big. It's something that you can just bite
No,
into the front. Or
no, it's like I use free things for the jig de Lucia and coins. I mix
Course
it
the programmer.
and create the program, and I put it into the anterior. The first time I do it with all the jaw, but normally this structure blocks the premolar and posterior part. So I start to make in anterior part, and this is fantastic because create like a natural guide. But probably the guide is in this position, in this position. It doesn't matter for me. I want to release and take show the system, all the brain, a reset position, and the physiotherapist work with this fin, this spleen, uh, without this spleen until we have improved that tissue damage or pain, when we or both at the same time. When we get this, starting to teach the patient how can you arrive to this position, how can you do this in this position.
I see.
We do it in the night and in the day. He has to have conscious of the position of the mandible into the craniomandibular system. I don't know if I explained it right.
Gerard, at what stage, or do you at all consider facial aesthetic in your treatment? When do you start thinking about that?
Are you, Hamid, are you from 70s, 80s? Are you you born in 70s, in 80s, in 73? I want to tell you. Imagine that I'm going to buy a 73 Ford Mustang. We arrive, and when they open the garage door, we find a car in perfect condition. What is the first question do you ask?
you never ride it.
Does it turn on?
Yeah, and then and then you say, can I try it? And what do you want?
No, you don't touch it.
No. We want to try it with the hardest macadamia nut that you can fight it. I never eat macadamia nut, but I want to prove it. This is my 73 Ford Mustang in perfect condition, but I want to prove if it's the capacity to run at 170 miles per hour. Why? Because you want to try it. And the 73 Ford Mustang may be in perfect beauty, but it should also work with the problems that a 73 car brings, such as having lost teeth, or need to put implants, or you have to warm so much that you have to recover the some broken parts, whatever.
Correct. So
this is the point. 273 but look like a car from that year, not a 22 model, not a 2020 model. You have
but
to.
as you know, people, even though they may come with pain, or in a lot of times, our patients come in thinking that they only have dental problems, right? And they're interested in a nice smile. I mean, Javi and I work on these type of cases all the time, and then we have to tell them, hey, this is why you broke and destroyed your teeth to get in here, and this is why we have to do our modality, correct? So we've gotten used to kind of like, even though we need to first deprogram the system to bring him to a baseline, correct? A healthy baseline before we structure. But from day one, we start to look at facial cues and aesthetic cues, correct? And deciding, you know, this is going to be like a range for our vertical. We don't want to go beyond that because it's not going to look right. At the same time, we have to fit all that health and function in that same space. So we wanted to know.
I am not the dentist for that people. I am not the dentist for that people because they searching for me because dentists do that. Dentists do that. First aesthetics. First, it's so hard to know how to breathe at 73 Mustang model. Obviously, it's hard, and probably you spend 6 months or maybe a year, and you have to wait for that. Yes, because I want to do a very good job. I don't want to do bad jobs. If you want very aesthetic, fun teeth, but without function, go there. Here is different. Here is different. You have to learn how to use it. You have to learn how to take care of your new aesthetics things. We do a very, very good job, and probably I'm not the dentist for that people. I'm sorry, but this
no, there's no right and wrong, Jerry. There is no right and wrong. We're just trying to formulate these answers in the questionnaire, and there is, listen, there is a 1,000 different ways of doing things, and obviously, you know, we know all our clinicians that we've invited are excellent clinicians, and there is no one way of doing things.
And right. I want to tell the beauty of the classic is that are preserved in the best of condition, the
that's fine. You're
function.
talking about biomimetics and making things look like the way. But,
yeah, we have to make beautiful teeth.
That's also
but at the same art.
That's
at the
yeah,
same
that's
art
also
they
aesthetic.
so. Natural wear, anterior. It's the theory of dental tegosis. Everything is in that. In my opinion, beauty is the wrinkle in how it looks and how it smiles to me.
100% agree. We don't disagree. That in itself is an art and a beauty to make things look very natural. Let's talk about the growth factors and do you have any familiarity with, for instance, PRGF? What's that?
We use platelets in guided bone regeneration.
You're in Spain, and Spain is pretty big with.
We use it. We do not use in temporomandibular joint. Yeah, but the results we obtain without thinking that it's not necessary. But if we had a case, absolutely always, I will not hesitate to use it.
Fantastic. All right. So question number 9. We're at the 9. I think it's a resounding yes. Because you're a posturologist, we're asking everybody, are you seeing postural changes? Which I'm assuming that your work is really based on bettering the postures, correct? Are you seeing, are you
Yeah,
obviously
the
monitoring
change
and
must
you're
be
seeing
evident
improvements?
and the examination must be improved. All if does not happen as we predict,
Then
as
there's something wrong.
is that we fail in the diagnosis. Something is failed. We, the postural is in
Inseparable from
before, in, and after
during,
of the treatment. We use the posturally everywhere, in each part of the diagnosis, each part of the treatment, and each part of the prognosis.
Fantastic. Let's talk about the education. I understand that you are you do teach at the university and consult there. How do you see the possibility of incorporating some of these ideas into?
Yes, we are solving little our seed every semester at the International University of Catalonia. He left me. He left me do whatever I want. We are doing tests to able to validate our results. This year, I'm directing 3 theses, one in dental faculty, but the others in faculties such as optics or podiatry, on the relationship of the mouth and the other structure. We are doing a doctoral thesis on the movement of the ICP. Many dentists come to learn what we do. We have been making way for many dentists, and
that's fantastic. So
now, well, we great trips start with one step, and we already took that one. I think we are inside the universities, and we all just try to do conventionally and structured science about this, what we believe.
Fantastic. Very well. Now I know you're, based on what you've explained, you guys maybe not so much, you rely on other factors, let's say, to do this. But do you guys ever look at the specific kinematics and the movement inside the joint?
Yep. We see.
What do you think is going? Can you tell me about the movements? Are you thinking there is rotation, translation, concurrent
in
movement?
healthy but not healthy joint?
No, ideally healthy. No, we already know.
Healthy. No, I think.
I know we don't see it. I know we don't see it, but let's dream about.
Imagine in my practice, all my patients are asymmetric. Every patients are always asymmetric.
Correct.
They are always unfunctional. Well, parafunctional, better.
Correct.
And I treat everyone like this, asymmetric and parafunctional. And I want to have a healthy system, a healthy body. And that means
let's think about. Let's talk about in an ideal healthy joint. How do you see the kinematics happening between the condyle,
with a hinge joint rotation axis?
No. Do you think
basically this is what we're trying to find out? It is a hinge axis rotation.
The lateral, yeah, in the lateral, go lateral to other lateral. Is a position, is a reference position.
No, yes, but what we're trying to describe here is the momentum, the events that happen inside the joint. You and I, we spoke multiple times about this. You already seen the research that I have with the instrumentation that we use. And honestly, I just trying to describe what I'm seeing with my eyes. That's why the reason that we're doing this. We're trying to standardize many of the concepts that people say, maybe they never have the chance to see it. That's why my lecturing Friday, I will show some of these, and then we as a group, we will see if what I'm seeing is right, and I'm looking for for opinions. So when we try to describe it, do
you
you think
see,
that is a rotation first and then a
you
translation?
always see a lateral. You always see a lateral torsion movement before, or not?
Okay.
I
No, I'm talking about the
see.
joint. Is a rotation or a translation first?
We're talking about that moment of
the joint.
opening, Jerry. We're opening. When we go to open. Yes.
I think it's laterally. If it's not healthy joint, laterally first.
No, but you get to another different dimension that we're talking about. My God, you made it right.
Okay.
No, we're talking about sagittal view of the conda, and we're talking about is an initial rotation and then a translation, as the book said, or is something that is coming
at the
together?
starting of the movement.
Yeah.
If you have a poor rotation at the starting movement.
That's what we're asking. That's what the literature say. The literature say that you have 2-3 millimeters.
No, it's impossible. A pure rotation, it's impossible. It's not. You have to take a CBCT. There's no. The condyle is not around. It has a typical shape. It's impossible to rotate with this form. It's impossible with this shape. It's impossible for me, obviously, no? I don't know.
So you can say that is a translation and a rotation combined, that what you can say? Okay.
Yep.
Very well. Thank you so much.
Every people in the house are so angry with me about the
But
no,
that's okay.
You know,
we are igniting passion, and that's a great thing. Honestly, we're all passionate about what we're doing, and that's why a couple of crazy guys are doing this for 8 days in a row.
I'm not a crazy guy, man. I'm Batman.
Okay, so
I want to kill you. You know my secret.
Now you know why I need 4 days with 4 nights, like 2 cigars for every conversation. I have a bottle of scotch every time that I was talking with Gerardo. You see how passionate he is.
I will try to be simple, but it is more complicated.
Believe me, he make a huge effort to be simple. This is not the way that he normally talks. He takes many.
Sounds like when I.
But I love it, honestly. Maybe
I will try to do my best. I'm very simple, but it's so complicated. I can show you exactly what is the way of pathway of the trigeminal in the brain, but this is not.
Just remember for the lecture. Yes, okay. We want that you show really what you do. Just remember that in the Friday we're gonna be political finishing at the 30 minutes because as a fact I have one speaker that I need to still feed it up because
I will try to do in 30 minutes.
30 minutes.
I'm absolutely sure.
Now I'm gonna tell you something that I'm gonna do myself because I have similar personality that I want to go and I never on time. I'm gonna record my lecture to be fair. So because I want to be neutral, I'm gonna record my lecture. It's gonna be 30 minutes that I just need to put play. That's it. I contain the material and the points I want to highlight.
I will do. And a lot of information. So you have to stop it and say, "Oh, what a handsome guy! I want to hear it for all my life." Yeah,
you guys see, that's what I love.
It must be something Colombian in there, huh? You guys in love with yourselves.
Look at me, I am a very handsome guy. Oh, it's
and he doesn't know how to dance because he's from Bogota. I do know how to dance.
Okay.
Anyways, love you, Gerardo. Amazing. Thank you so much. Thank you, everybody.
I love you. I'm so sorry for the.
Don't be sorry. We love you because who you are. That's what it is.
Yes,
independent of the opinions.
My point of view.
I know, and thank you because this makes us think that eventually it's a fact that Hamid and we're gonna continue doing this, not with this intensity because we need to figure it out how we're gonna feed our families after this process, right? But at least try to keep doing some. Yeah, but then we want eventually to bring more people related with this and learn more. Honestly, learning doesn't hurt nobody. Honestly, and for the people that is watching this, we're going to have something for somebody that you guys can share with us. But remember, everything is an friendly environment. We don't want to prove that nobody's right or wrong.
As a matter of fact, they should suggest. They should say people should suggest people that we can invite and that can.
No, even Gerardo has somebody, but I didn't want it because that was not the purpose of this. Gerardo told me honestly, I think I take things for the School of Vienna, but I'm not. Let me put you in contact with my teacher, and I say, Gerardo, this is not about this. It's about you. You have the connection. I will respect your teachers, but we don't have this personal contact. And to me, this introduction to talk about occlusion start for the heart, start for that connection that we have as human beings by passion.
Kind of like an introduction for ourselves, because all of these have affected and has had a movement in the way we do things. So it was important for us to bring people.
If I want something structured with perfect motion, perfect position, and perfect width, I use a Slavic concept. But I am a Latin guy. I told you, I use whatever I want. And if I have to use, I don't know, another things, I use it with another science. And then
and that's good. It's good to mix. There's nothing wrong with that.
The goal is another thing. The goal is the health of the patient.
That's correct.
Not to have the reason, not to do the things like this or like this one.
All right.
Yeah, it's not always a straight line, the closest distance between 2 points.
All right, my friend.
We
did it again. We have gone 42 minutes ahead of our allotted.
Oh, well, this is because I am a very handsome guy, you know that.
So thank you, everybody. Before we cut